Looking at these various aspects of stent thrombosis, stent, the spontaneous bleeding, because the problem, whenever we give dual antiplatelet agents, it's not necessary that everything is fine because they come at a cost of bleeding. The stent thrombus, preventing thrombosis, stent thrombosis and spontaneous myocardial infarction is an advantage, benefit, and the propensity for spontaneous bleeding is the harm. So we have to tailor both these things and decide the duration, and in this regard some certain DAPT scores are also developed. So what are the factors which increase the ischemic risk? The patient related factors are the advanced age, ACS presentation, the patient presents with myocardial infarction or ACS, prior myocardial infarctions, again the same thrombotic milieu in the patient, extensive coronary artery disease, diabetes and CKD. These are the factors which increase the propensity for thrombosis, whereas the stent-related factors like who presents with ACS, again diabetes or ejection fraction is less than 40%, first generation DS which are no longer used, or the stent technique is a problem. You are undersized or under deployment, you didn't have good apposition, you have taken a smaller diameter stent and the bifurcation stent and longer stent length and in-stent restenosis. These are some of the stent-related factors which increase the propensity for thrombosis. Some of the factors like in the bleeding and the thrombotic risks, the same thing applies here. The same factors which is predisposed for stent thrombosis are also related to the bleeding in general. For example, the patient, elderly patient, female sex, and the patient who is on oral anticoagulants, history of prior bleeding, taking concomitant drugs like steroids and non-steroid anti-inflammatory drugs, so CKD, anemia, these are all the factors which lead to the increased bleeding risk in these patients. So whenever we have to take all these things into consideration, and also we have to take into consideration whether the patient presented with stable angina pectoris or unstable angina pectoris, acute coronary syndrome, or patient has what is the propensity for ischemic events or bleeding events, and what is the overall mortality in this cohort of the patients. All these things we have to take into consideration before looking at how long we have to give the DAPT, dual antiplatelet agent. The DAPT scores are developed based on the thrombotic and bleeding complications. Here you can see the scores. Unfortunately, now you can see it. And all these factors, if you see as the age advances, you get negative points. And the prothrombotic factors like diabetes, MI at presentation, prior PCI, lower stent diameter, all these things give a positive risk factors. So when a score of more than 2 is there, that means more thrombotic tendency and patient is likely to develop stent thrombosis. If the score is less than 2, he is likely to develop bleeding risk. There is another DAPT score, precise DAPT score. These are available on the net, somebody can download it. In the precise DAPT score, as compared to DAPT score, only 4 or 5 points are taken. They are hemoglobin, WBC count, you can see there on the left side, age, creatinine clearance, and prior bleeding scores. So in these scores, when the score is more than 25, that is the bleeding risk is more, so you give DAPT for shorter duration. And if the score is less than 25, you can give for the standard DAPT duration can be given. Now you have to understand this concept very clearly. When the DAPT score is more than 2, that is easier to calculate, and you can download the app also. If the DAPT score is more than 2, the number needed to benefit is only 34. If the DAPT score is more than 2, number needed to harm is 272. So there is a significant benefit of giving dual antiplatelet agents for these patients. Whereas if the DAPT score is less than 2, there is no reduction in ischemic events, but number needed to harm is only 64. So you can understand such a clear-cut difference between the DAPT score 2 and less than 2. It should be a practice of all the clinicians who are doing coronary interventions and are following the patients to have this in mind and calculate the DAPT scores. So here, what are the specific recommendations? Ticagrelor, these are the category of recommendation, level of evidence. All these things I am sure you are familiar with. The ticagrelor may be used in preference to clopidogrel in post patients after PCI with stent. This is class 2A. Prasugrel is also potent antiplatelet agent, but the problem with prasugrel is you should not give it to patients who have got prior stroke or TIA, and you should be careful when you are giving for people more than 75 years and less than 40 kgs weight. And what are the recommendations of DAPT in ACS presentation with DS. See, the DAPT duration is dependent on the clinical presentation, whether the patient is presenting with stable ischemic heart disease or acute coronary syndrome. The person who is presenting with acute coronary syndrome, you have to give 12 months DAPT, whether or not you do bypass surgery or medical management or stent implantation. This we know from the CURE trial. So we have to the DAPT, when you have PCI, it should be given for 12 months. And one important point to remember, there is no advantage of giving aspirin more than 100 milligrams per day. It only increases the bleeding complications and does not reduce the thrombotic risk. And all recommendations imply that aspirin is given lifelong to these patients. So the only question is whether you are going to add any of the other antiplatelet agents or not. And when you give aspirin, just keep it less about 75 or 100 milligrams per day. And ACS patients, ticagrelor may be preferred over clopidogrel. We know it from the Plato study. And when prasugrel is not a bad idea, from Triniton trial we know that provided the patient, as I mentioned, the complications are not there, the contraindications are not there, risk of bleeding, continuation of DAPT may be reasonable. This is a subset. Now, when we say stable ischemic heart disease, actually I don't know whether what is your experience, I don't know, but personally I think most of our patients actually present with acute coronary syndromes or acute myocardial infarctions. The society, in our society, they present like that. So a patient who had MI and after a few months he is considered as stable, and such a patient can be considered as stable ischemic heart disease and go for prolonged DAPT. And patients who are tolerating and not risk for bleeding also can receive DAPT, that I told you, to prevent the spontaneous myocardial infarctions. And if the patient receives in stable ischemic heart disease post-DES, you can stop dual antiplatelets after 3 months if the patient is at high risk of bleeding. So the presentation with acute coronary syndrome itself indicates that the patient has a thrombotic milieu as compared to a patient with stable ischemic heart disease. And stable ischemic heart disease you can stop after 3 months. And following bypass you can give for 12 months if the patient presents with the ACS. And medically managed patients, there is no reason to give DAPT. Purely medically managed patients who don't have ACS, there is no indication for dual antiplatelets. Now, as I was mentioning earlier, the reduction in stent thrombosis with DAPT is 0.4% versus 1.4%, and reduction in MACE is 4.3 versus 5.9. Reduction in rate of MI attributed to prevention of spontaneous MI is highly significant, 2.1 versus 4.1, and increased bleeding is also risk, 2.5 versus 1.6. So it's a trade-off. You prevent thrombotic events at a cost of increased bleeding, and the most important thing, there is slight increase in mortality, which however is not statistically significant. So don't think that you are doing wonderful job just by giving DAPT. So this is algorithmic table. Quickly we'll go through. Stable ischemic heart disease patients, if you put a bare metal stent for 1 month, drug-eluting stents for 6 months. If the patient has bleeding, stop after 3 months, and if the patient is not at risk for bleeding, you can continue more than 6 months. And same thing, patient presented with acute coronary syndrome, you give DAPT for 12 months. If the patient has a tendency for bleeding, stop after 6 months. If the patient doesn't have a tendency for bleeding, continue for more than 12 months. And medically managed patients without history of MI, PCI or recent MI within 12 months or this one, there is no role for DAPT. This is one point which is really disheartening. I do not know. It is very disheartening and depressing to see a patient who does not have acute coronary syndrome, does not have stent implantation, receiving dual antiplatelet agents and coming with an intracerebral bleed. I have seen umpteen number of patients. Actually, I want to project one of my patient's photograph. He's in deep coma now. 4 months, it's a real struggle. And the patient didn't have anything. A diabetic patient, that's all. So the Karishma trial has clearly shown that there is no advantage, though some subgroup analysis may show that some patients may benefit. But mind you, if the patient does not have myocardial infarction and stent, don't give dual antiplatelet agents. Now, the certain special situations, patients with triple therapy, we should be very careful. That is oral anticoagulants, apply the bleeding scores, and consider a target INR of 2 to 2.5. Keep the duration of triple therapy to as short as possible. And whenever you use this, use clopidogrel, not other doses, and use low-dose aspirin, and PPI should be preferably given in these patients. And the two myths that we should know, that there is no scientific rationale for doing genetic testing to determine whether to give which kind of 2B3A inhibitor, P2Y12 inhibitors. And second thing is, there is no rationale, no scientific rationale for switching from one antiplatelet agent to other antiplatelet agents. And you have to take measure to minimize bleeding. These are beyond the scope of topic assigned to me. Most of these things are covered. And sometimes, though we will be compelled to change clopidogrel to ticagrelor or prasugrel, these are some of the charts available. Only one study is scientifically valid, all others are expert opinions. Only changing from clopidogrel to ticagrelor, you give 180 milligrams of bolus dose. Otherwise, in acute situations, you give loading dose of other drugs like prasugrel or ticagrelor and changing from whichever drug to other drug. In chronic setting, you don't have to give the loading dose, you just change from the next dose onwards to other drug. The only thing, I think, more than the topic assigned to me about the duration, I think I'll benefit the audience more if I can emphasize to them that DAPT is not indicated in purely medically managed patient without prior PCI with stable coronary disease and no history of prior MI. I would, with the apologies to the organizers, I would like this point to be taken home, apart from the other things which we are overdoing actually. Thank you very much.